would like to welcome Dr. Bruce Patterson. Dr. Patterson comes to us from the United States, where he completed his bachelor degree in medical school in northwestern Michigan, and then completed a residency in pathology and a fellowship in molecular virology. And he served as a virologist since then in Illinois and then in California, where he is an assistant professor. He is appointed now at Stanford in the Department of Virology, where he served as a director until 2012. He is awarded and honored by multiple societies, and he serves on multiple committees, especially in national committees in the States, like the NIH AIDS Immunology and Pathogenesis Studies section. Multiple awards, multiple publication, and multiple grants nationally and internationally. I would like to welcome him to speak to us today about the staging cervical precancer, including checkpoints, inhibitors, markers, and expression, implication for early non-invasive treatment. Dr. Patterson?
Thank you. I'd like to thank the organizers for inviting me. It's certainly a pleasure to be back in Lebanon, where it's so welcoming. I'm going to go cellular on everybody today after that fine lecture before on the gross morphology of the female genital tract. And my company now and my life's work has really been based on the ability to detect genes, proteins, and pathways of disease pathogenesis while keeping the cell intact. These days, we're so accustomed to hearing about next-gen sequencing and PCR and techniques that really destroy the cells and recover nucleic acids, followed by amplification of certain genes. And they give you great yes-no questions. But the reality is, in medicine, we deal with pathways. And what I'm going to talk about today, being a virologist, is HPV and how it's involved in the pathway of cervical cancer. The key thing to remember is the viruses are viruses. You have an infection. Disease is an entirely different subject. When I used to teach at Stanford, I used to talk about viral commensalism. We all have viruses. Most of us probably have HPV. Most of us probably have herpes. Most of us probably have CMV. But most of us have rhinovirus in the nose. Am I going to give you $800 worth of ribavirin to get rid of it? No. The point being is we all have viruses, much like we all have bacteria in our gut. The goal is not to sterilize the human body from the gut microbiome all the way to whatever viruses are either latent or persistent in our body. The key is to identify when they cause disease. What happened was in the 1990s, a colleague of mine, Harold Zurhausen, who later won the Nobel Prize for HPV in 2008, discovered that 99.5% of cervical cancer had HPV in it. The problem is that caused a misconception that having the virus means you have disease. And I'm standing here today saying we have a test now that can really determine the difference between having a viral infection and disease. I get calls all the time from distraught men and women who say, oh, I have high-risk HPV. You know what my first response is? So what? A lot of people do. Very rarely it goes on to cause cancer. My point to them is we need something that says it's actually active and in the process of causing cancer. And oh, by the way, I'm going to tell you where it is in the process. Isn't that how we want to counsel our patients? I'm here to help you talk to your patients about what they have instead of using the word risk. The word risk in medicine is very, very dangerous. If you have a 50% risk of having something, if I was a patient, the first question would be, well, am I in the 50% who doesn't have disease or is not going to get disease, or I'm in the 50% who does? That's a failure of us on the diagnostic side. And what my life's work has been about is changing that and making sure I can tell a patient, you have this, you are right here, this is what's going to happen. Then have an informed decision instead of throwing the onus on the patient to make a decision. When we talk about risk to a patient, what we're saying to the patient is, you decide based on the risk what you want to do. And again, I think that's unfair, and I think it's unfair to the patient. So the focus of what I've done my entire life is to really incorporate actual biology in a diagnostic. I don't want an easy yes-no answer. Looking for HPV, looking for herpes, looking for Epstein-Barr. Those are easy yes-no. Is it there or is it not there? That's analytical sensitivity and specificity. But as physicians, we're in the business of clinical sensitivity and specificity. The other great case I used to teach at Stanford was about HPV DNA. Hybrid Capture 2, which was a 1980s technology, had an analytical sensitivity of 50,000 viral copies. You needed 50,000 viruses in a small tube to say, yes, you're positive for HPV DNA. PCR came along and said, wow, I can take that down to 1 to 2 copies in a tube. But what was the difference in the clinical sensitivity? 0. They had the same clinical sensitivity. What has happened these days is the companies talk nothing more about anything but analytical sensitivity and specificity instead of clinical sensitivity and specificity. The reason is HPV is a high viral load disease. There's lots of virus. So a bad 1980s pre-PCR technology was actually pretty good at determining who had disease with a 90% plus clinical sensitivity. Cervical cancer is not an infection, but requires it. Okay? Epstein-Barr causes nasopharyngeal carcinoma. I don't see people reacting when adolescents have mononucleosis. Do we start biopsying the nasopharynx to see if they have nasopharyngeal carcinoma? Okay? We need better tools to be able to say what's going on in terms of disease. And we need to understand the dynamics of gene expression and cell cycle at the cellular level. Lysing cells and doing some molecular technology has destroyed the context from where those genes came from. The uniqueness about the technology I'm going to present today is that we keep the cell intact. So we have a lot of the attributes of the pap smear that were useful, i.e. the cell, and the changes in the nuclear to cytoplasmic ratio that occur over time in the cell, coupled with some of the newer molecular information that tells you exactly what the virus is doing, so that we can unequivocally classify where you are in pre-cervical cancer, so we can counsel our patients appropriately without having to say risk of this, risk of that, 20% risk, 4% risk, and have them have to make the decision of what to do. This is a slide that we've probably all seen before. This is the pathogenesis of cervical cancer. We get HPV infection. We go to SIN1, which is a very reproducible diagnosis, SIN2, which is not a very reproducible diagnosis for pathologists, and SIN3, which used to be called carcinoma in situ, and finally cancer. HPV DNA does two things. Number one, it detects way too early in this process because our cutoff for treatment is right around SIN2. Now it's becoming even later, probably closer to SIN3. Okay? HPV RNA is actually very, very useful because it comes up right where the treatment decision is made, and it stays during cancer. You know what HPV DNA does? It comes up early, and it has only 90% sensitivity for cancer. It goes away because the virus has lost its cells that it needs to replicate more virus. The other thing we completely forget about is the immune system, right? A lot of times when I talk to people and they're talking about disease, they want antibiotics for viral infections, all of these things. Why? Because they forget that we actually have an immune system. Immuno-oncology has taught us the power of our own immune system. PD-L1 inhibitors are taking away the short-circuiting of the immune system that the tumors do, and the immune system is perfectly adequate to fight off tumors, given the right conditions. So we completely forget about the role of immunity in regression of cervical disease. And when you look at it, the figures are surprising. SIN1, 60% regress on their own. Why? Because we have an immune system. SIN2, about 50-50. The most surprising fact on here is that 30% of SIN3s will either stay the same or regress. Of course, none of you are going to sit on a SIN3 and not do anything. But the fact is, we know from the older population, there were studies that were done in nursing homes that found that older women had SIN3s and probably had it for years, and they just didn't do anything. So we need to understand the factors that are causing cervical cancer to progress and put those in a diagnostic. That's why I'm here. Okay? We need to factor in the immune system to see how that plays a role. Again, that's why I'm here. This is the pathway by which HPV causes cervical cancer. Okay? There's multiple steps, but there's two important steps. The red arrows are the upregulation of E6, E7. Upregulation is a word that infers quantification. There's other qualitative tests like Aptima that say, oh, there's E6, E7 present. That's not enough. Small amounts of E6, E7 are being made early in infection, okay? Who cares, right? But when E6, E7 are upregulated, that's when this cascade begins. That cascade then goes to proliferation. HPV Oncotech 3DX, which I'm going to talk about today, quantifies both E6, E7 and proliferation. Two steps in the cervical cancer pathway, not in the HPV pathway, the cervical cancer pathway, because proliferation is a cellular event, and that leads to progression. So this test tells us where you are in disease progression. Are you going forward? Are you regressing? Are you staying the same? You know, and you can counsel more appropriately to your patients. This is something I always put up because it shows the difference between the molecular events of infection and morphology. Morphology comes late. That's why the pap smear is going away for most part, or we're trying to get it to go away, because all the changes in the morphology tend to happen well after the molecular events. Well, how about a test that combines both? Some size, some nuclear cytoplasmic ratio changes, some cell cycle that goes to the cellular level, in addition to some of the molecular events that cause cancer. Here's a great slide. In a productive viral infection, you have lots of L1, lots of L2, lots of E4, very little E6, E7. Cancerous lesions, high E6, E7, integration E2, loss of L1 and L2. Why is that important? You know what cobas PCR detects? L1. It's called L1 deletion. It's a big cause of false negatives. Okay? Everyone tends to think that HPV DNA testing has no false negatives. Well, you're wrong. And this paper turned the field on its ear a few years ago at Urigen. Why? Because they took 4 FDA-approved tests. They took the same sample and they split it into 4 ways and ran the test on each of those samples. You know what they found? All the tests that are currently out in the market, 29% concordance. 29% concordance. What does that mean? Every single test relative to the other has both false negatives and false positives that are unacceptable. Why should we even trust HPV DNA? Any more than we can trust the morphology of pap smears. We need more. We need more information. This is a test that we've brought over to Lebanon. We've been running in the States for over 6 years now, where we quantify on the lower panels the amount of E6, E7 in a sample. This is all cells. All those little dots are cells. We can analyze millions of cells. If you look at a slide on Pap smear, maybe you have 5,000 cells in the slide. This machine can analyze millions. And we're looking at oncogene overexpression and proliferation, the two markers that I showed you in the mechanism of cervical cancer. Here's another case with an LCIL pattern. High E6, E7, no proliferation, right? Remember, a high-grade lesion is going to have oncogene overexpression, proliferation. A low-grade lesion is going to have oncogene overexpression, no proliferation. Simple, without even doing a biopsy and histology. We can stage cervical cancer using these two biomarkers. This is an amazing study done by a laboratory in the United States. On the orange, you see Kobosh Roche, Hologic GemProbe, QIAGEN BD, all HPV DNA tests. You see IncellDX, Oncotech 3DX next to it. The negative predictive values are the same. Okay? Back in the day when you used to listen to Digene speak in the 90s and early 2000s, all they talked about was sensitivity and negative predictive value. Why? Because they're the same thing, essentially. They never touched specificity or positive predictive value. Okay? So what we've been left with is a number of HPV tests, cervical cancer tests, with extremely high negative predictive value and sensitivity and horrible specificity and positive predictive value. What has that done? That red bracket around the blue bar is the number of clinical false positives there are out in the field. 80% clinical false positivity rate using HPV DNA for screening. Terrible. And it's a terrible use of healthcare dollars because that many people have to go on to invasive procedures for confirmation. This was a study we did with HPV Oncotech. What it did is showed very nicely on the lower row a combination of abnormal Pap with HPV Oncotech 3DX had the highest sensitivity, the highest specificity, the highest negative predictive value, the highest odds ratios, the highest positive predictive value as a combination. It's a great combination used for co-testing. Here's another part, age 30. Have you ever wondered how they chose the age 30? I always tell this story. This is a great story for gatherings of friends and family, where the woman's 29 years old, walking down the street. Her birthday's tomorrow. She turns 30. Oh, I got HPV. Right? How'd they come up with 30? Well, I was on the FDA panel in the late 90s when Digene first submitted their data. And it was horrible when they looked at over 21 all the way up to 75 years. It was horrible. What they did is they went back and parsed the data due to age groups and found that over 30, the data at least looked decent in terms of a diagnostic test. Then they created a backstory that if you're 30 and you have HPV, it must be persistent infection, and that's the folklore that's followed it, okay? The bottom line is HPV DNA does not do a great job in the younger age group because they get transient infections because they have a great immune system. And we all know as you get older, your immune system gets worse. That's why you'll see in 70-year-olds and 80-year-olds, all of a sudden they have SIN3 and some active disease because the immune system's getting worse. This is what E6, E7 mRNA and cell cycle can do. We get a perfect graph with a perfect population of SIN2 and SIN3 with very little else. We can stage HPV disease that way. We can say if it's low grade or high grade based on E6, E7 and cell cycle. because we know that pathway that I showed in the beginning of the talk.
Dr. Patterson, we have a couple of minutes to wrap up.
I'll get there. This is the AUC curve. The AUC curve, 0.9 AUC under the curve. 93% sensitivity, 80% specificity for a high-grade disease in one test. It takes 3 hours. Okay, not a battery of tests, not a combination of a sensitive test and a specific test, one test. That's extremely powerful. And it creates an algorithm that we can all understand. I'm sure you've seen other algorithms. They look like spider webs. If this, then that, if this, then that, if this, then that, if this, then that, and that. It's quite simple. If you have abnormal cytology and you're E67 negative, wait and retest in 6 months. If you're HPV positive and you're E67 negative, wait and retest in 6 months. Ask us HPV positive and E67 positive, colposcopy. Easy. If you add in PD-L1, which is the new marker for immune responsiveness, look at this case 18. High HPV, high PD-L1. That patient's going to progress because the PD-L1 is inactivating the immune response. Okay? Then the two over in the end. High HPV, but no PD-L1. So despite the fact that they're high grade, there's going to be an adequate immune response against those. We're starting to roll in the immune response. We're not there yet, but this is where we're headed in the United States. So I'm very pleased because we've been able to bring this test to Lebanon, and I'm very excited to do that. We've been running the tests all week. They're available at BPI. Again, this is the laboratory where they're done. High throughput, 96 wells, 96 at a time in about 3 hours, 1 day turnaround time, a single test with combined high sensitivity and high specificity. Not a high sensitivity DNA test with very low specificity, reflex to a PAP with very high specificity. One test, 3.5 hours.
Dr. Patterson, we have to stop here because I'm pretty sure we have a couple of questions about this new test by the audience.
Here is an actual patient report. All the information I just gave you on a comprehensive report, easy to understand, easy algorithm for interpretation, better way to guide your patients. I've used it for 6 years now. We've used it in the United States. It's run at large reference laboratories in the United States. We've run this on over 500,000 patients worldwide, and we're very pleased to offer it here in Lebanon. Thank you very much.
Thank you, Bruce, for a comprehensive talk. It was a good talk. Few questions is, the test is not a primary test. As it is now, you're presenting it as a reflex test. You gotta have a pap smear with this test. So you're offering it as a co-testing or as a reflex testing. You have to be clear about this.
You know what the way we position it with our company around the world, outside the United States, it's a standalone. Especially countries that don't have the infrastructure to do one test and another test and then colposcopy and biopsy. Okay? So yes, it can easily be a standalone because of the combination of high sensitivity and high specificity. As you saw from a study on 11,000 patients with 1,200 biopsies, which is the same size as GenProbe and Hologic's PMA with the FDA, there was very high results co-testing with PAP and this test.
So in the US, it's a co-test or it's a reflex test?
It depends on the laboratory. We have one lab, bioreference lab, that offers it as co-testing. LabCorp offers it as reflex. It all depends on the laboratory. That's the great thing about it. It has the flexibility to be either or. depending on the clinicians.
What is the advantage of doing it as a co-testing compared to a reflex? I mean, you can just do the test. Why to do the other one? Is it money? Is it like
Cost.
expense? Cost?
No, it's not cost. You know what? It's a different situations in the States versus the rest of the world. This is CEIVD approved in the United States, CFDA in China. We have an intermediate level FDA in the United States called the ASR. The easiest road in the United States for us was as a reflex. That way we could keep our price high, and we got still a market size of about 2 million tests per year. That's plenty. There aren't 2 million tests to be had in countries like Lebanon or some of the other countries we're in, and they don't have the resources, so it's a great standalone. So why do 2 tests when you can do just 1?
Excuse me, question. If you go back to your algorithm here, okay, we can see your algorithm. When you state that when you have Ascus LCL, when you have Ascus LCL, HPV positive, and E6, E7, if you go back, if we can see the slide of the algorithm.
I can't go back. It's the next test. Just what's the question?
Yes, the question is, you say wait and retest all in 6 to 12 months. What are your results in the second run when you retest? How much you are finding positive results? You know what I mean?
In most of the cases, we do see a switch to positive probably in 5 to 10%. So I think it's useful to retest in 6 to 12 months. Number one, again, you are taking the no immune system approach to this. 6 to 12 months allows us to engage the immune system. How is that involved? Are we going to clear the DNA even?
And at longer run.
Can I finish? Allow the DNA to clear, okay? In a study in 1998 in the New England Journal of Medicine, they went from no infection to high grade. We know we have that window, that safe window of 24 months at least to be able to retest.
Yes.
And 6 to 12 months is certainly conservative enough to see how the molecular evolution occurs in these patients.
We will continue after.
We can talk outside.
Yes, you can continue that. Thank you very much.